Ahead and get started. Welcome everybody. Happy St. Patrick's Day. I see we've got a lot of folks on the call here, so that's fantastic. I'm gonna share my screen and just go through kind of an agenda, and then I'll flesh this out with more notes and then be able to send this out to everybody a little bit later this afternoon. So please bear with me while I get the share screen going. All right, so we'll start with our metrics and then case counts. Then we'll go and just talk about some updates about variants and wastewater surveillance and how that kind of ties into the trends that we're seeing both in the community as well as in our hospitals. Then I'd like to do just a little bit of thinking out loud and reflecting, and I'd love to hear from you both your questions and your understanding of where we are. But I think it's a good time for us to take the opportunity to think about what the future actually holds for us, as murky as it is. I think we've learned that, this pandemic is going to continue to throw curveballs, and we are best served when we prepare with the best information that we have. So, I'm calling this section, what does the best case, worst case scenario look like, just based on some of the articles that I've been reading. And then what will success look like for Fresno County, say a couple of months from now, later this fall, then later in the winter when we expect, some kind of a wintertime surge related to the different respiratory viruses. And then a year from now, whatever that may bring. I really think even though this exercise is by definition, set up to humble us and prove us wrong, because no one can predict the future. I do think it's important for us to go through it just by way of understanding what our goalposts at least should be and what our aspirations should be. Hopefully it's something that you find valuable too, and something that you're doing with your teams and your staff as you all prepare your organizations for the months and the weeks ahead. In terms of non-COVID news and announcements, I'll save those for the end, but we should have lots of time for Q&A and hopefully hear from some of you about how things are going. Let me just go to our CalCat website, which is found, so I'll share a different screen here and then go to this dashboard, which is our COVID-19 cases. So in terms of cases, as you can see, we've basically had 4 surges. One of them was massive, which was the Omicron surge that just ended really in February. And here we are in mid-March, and the numbers keep coming down. That trend is holding up. You're hearing things in the news about different parts of the world and possibly different parts of the country saying that their downward trends are actually kind of slowing and possibly even reversing. I don't know how much to make of that, just because the numbers overall are so low that, obviously you living in a state of perpetual alarm is quite counterproductive. And in my opinion, this is probably as good as things are going to get, so I think people need to hear that, and people need to try to take advantage of, the combination of great weather, low cases, and relaxed restrictions that we currently have, and really just try to enjoy this phase, knowing that it won't last forever, that we don't know what the future brings. I think that, as important it is for the experts and the epidemiologists and the investigators to be focusing on what the numbers are doing day to day, I don't think that it really serves us to alarm people unnecessarily about the fact that we are seeing tiny fluctuations. That's just my opinion. I'm happy to hear others, but that's kind of what I feel. I feel really reassured looking at this curve, and I hope all of you do too, that we are definitely in a really good place here in the county. Going down to just the total number of tests, we know that those always come down as people feel less symptomatic and have less of a need to test for things like workplace and school, et cetera. And obviously home tests are putting a big dent into the official testing count. I'll skip down to the hospital cases. And here's what the hospitals are doing. Again, The curves are even more accentuated here. So you can see that we had 4 kind of big surges since the start of this pandemic. And each one of them just really hurt our healthcare system in slightly different ways and in ways that possibly accrued on each other. Right now, it looks like the numbers are continuing to downtrend. We have 133 people in our hospitals and 19 in our ICUs. So from that standpoint, COVID is not really straining hospital capacity. But, you know, I worked last night in our low acuity area of the emergency department, and we were rocking and rolling. I didn't see a single COVID patient. I really didn't even see a single respiratory complaint, but I just saw a ton of everything else. Just really heartbreaking stuff because it was clearly related to pandemic stressors, including very young people in mental distress and drug overdoses and things like that. But, you know, it wasn't directly reflected in what the COVID statistics currently are. So we know that the hospitals continue to stay busy, but right now, COVID doesn't seem to be playing a major role in that in those numbers. Although obviously 130 COVID patients is still far from a minimal impact, but it's going in the right direction. I just wanted to point people to. Sorry, there's just a lot of other open windows here, and I apologize. I just wanted to point people to just a lot of the resources that we do have, including this one, which is our monoclonal antibody page. And this is something that, you know, Sim can probably drop this in the chat, but this continues to be updated, and we're using, even though we call it monoclonal antibody provider sites, remember some of them are also offering Evusheld for pre-exposure prophylaxis. So, you know, St. Agnes is doing this, UCSF COVID Equity Project is doing this. You can see Dr. Boz and the Fresno Nephrology Group and some of our other partners that are seeing immunocompromised patients, cancer patients, patients on immune suppressants. They are basically providing Evusheld. Please make sure that if you are treating immunocompromised patients, they really should be getting Evusheld. I mean, you know, there is a lot of kind of anxiety out in the community about how the restrictions are totally gone. You know, obviously that doesn't mean that people without immune compromise aren't at risk. We know that there's probably about 30,000 of those patients, given the national rate of about 3% of the American population is immunocompromised and would fall under the eligibility criteria for Evusheld. And we haven't delivered even close to 30,000 doses of Evusheld. So we know that we have a massive gap to fill. And at the same time, we're turning away the allocations that are being given to our county just because we don't have a place to store them. And we're really not going through those doses as quickly as we could. So please reflect on that. You know, think about ways how you could do this. If you want technical assistance or you want to talk to one of these providers, we're more than happy to connect you. Obviously, a lot of providers have figured this out and they're doing it. And those patients are very grateful and they're going to be protected for 6 months at a time from Evusheld. So again, you know, even though it is an investment of your time and a possibly a stretch of your skills, you could totally do this. If you're giving if you're giving flu shots or any other shots in your clinics, you could totally give Evusheld. And the same goes for vaccines. You know, we really need to be at a point where a person can walk into any door that has a clinical shingle and then get their COVID vaccines. And we really need to have those conversations with our patients who might be hesitating, still haven't gotten around to getting their vaccines or their boosters, and really press them to say, you know, these are still protective and these are still going to keep our numbers as low as possible. We know that when things are good, they get really good really quickly. And the opposite is also true, that when things get bad, they get bad really quickly too. That's just the nature of viral pandemics. That's just how explosive growth works. You know, the best thing we can do is protect our population so that we have as many people protected as possible. So all of this information is, like I said, being maintained by Dr. Zweifler and by our communications team and our staff here. And there's lots of information here for where people can get their Evusheld and also their monoclonal antibodies. If they do happen to fall sick from COVID and they're higher risk, then they can get their monoclonal antibodies. I haven't heard anything about the orals in a while, but what we're anticipating is that in the next month or two, those supplies are going to be really going up quite a lot. And so patients can expect to have a lot of different pharmacies that they can go to. I know the White House's plan was to actually have a patient go to a pharmacy and then get tested. And if it's positive, then go ahead and get an oral medication. That's fantastic if it works. I just see a lot of kinks in that, having done this for a while. I see a lot of ways that that could actually fall, people could fall through the cracks. And honestly, it's like, I don't know how pharmacies would feel about symptomatic COVID patients coming in to get a test. So I'm not sure that that's a perfect mechanism, but that may be another paradigm that we see, is that, pharmacies take up more of a role. But right now, as medical providers, we are still in the mix, and we still have to be a really important piece that links people into care and gets them the prescriptions or the monoclonals that they need so that they can stay out of the hospital and stay protected. Any questions about that or any comments? I'm not sure if Dr. Z is on, but feel free to speak up if you'd like, Dr. Z. Okay, let me go to just the statewide forecasts. This is, like I said, opening a discussion about best case, worst case scenarios. And this is a CalCat curve that shows what's going on in the different health officer regions. So here's the Bay Area, and then here's Greater Sacramento. And what this number reflects in the yellow box is the R effective, which means that, when it's less than 1, that's pretty good. When it's green, it's even better. But when it's less than 1, it just means that the transmission is very low and that we expect this disease to kind of, peter out, as it were. Not that COVID will ever peter out, but we expect it to have very low transmission. And here in the San Joaquin Valley, this is what we're seeing as well, along with the rest of the state. So everything looks pretty rosy from a perspective of transmission. The forecasts are just not working today. So unfortunately, sometimes this site crashes a little bit, and then they have the actual number of hospitalized patients going down to 0. And I've emailed them. I've actually, had a little tantrum on my email to tell them that this is just a really distracting glitch that they need to fix. And I know my colleague Simon Paul, who's on this call, has more eloquently pointed out some of the limitations of this website. But nonetheless, this gives you some good trends about what things are doing and where we expect things to go. And here's what Fresno is probably going to do. Just keep in mind that we don't have 0 patients in our ICU. We have in our hospitals, we have about 130, but this is what they're expecting it to do over the next month, which is to continue to decline. I don't know how much that helps. Like I said, I can't help the fact that this site is really glitchy, but right now, this is the only epidemiologic forecast data that the state provides for us. And so for what it's worth, I do take a look at it just to see if it's valuable in terms of future planning. And for the most part, it has been accurate in terms of the broad schedule of the surges. So it was pretty accurate in letting us know that our Omicron surge would last into February. And here, I do believe that it is accurate when it says that our numbers will continue to decline for the next 6 weeks or so. Any questions about those trends? In terms of what's going on with our wastewater surveillance and our BA2 variant, so with Omicron, there was actually 2 different variants, at least, that have been kind of identified as variants of concern. And they were both described on the same day in the same batch of patients in South Africa. One was called BA1 and the other one was called BA2. Well, the BA1 took off very early. And that was the one that really created the Omicron surge in many different countries and many different states, including ours. And then the BA2 was just sort of dormant from what I understand, but then it took off a little bit later. And then it was found to actually be even more contagious and possibly a little bit more virulent than BA1. And that is actually what is now being seen at an increasing clip whenever the CDC checks the variants. And what they're saying is that, last week or maybe March 1st through 10th, the BA2 variant was like in 13% of all of the different variants that they saw. And then the next week it jumped up to like 25%. Again, very small numbers. So you do have to keep that in context. However, it is increasing in terms of its proportion related to the other variants. And whenever I share out these notes, I'll share the CDC data. I don't want to dig through my my Google right now to share that with you. But I took a look at it and I was like, yeah, that makes sense that the BA2, which we know is more contagious and more virulent, is now taking off. Whether it's really going to disrupt enough to cause another surge, I don't think anyone's really predicting that. I think they're just saying that don't be surprised if BA2 shows up in your neighborhood and, you know, possibly if it doesn't cause an uptick in your numbers, it may actually slow things down to where you don't really see a decrement as fast, which I think is a fair interpretation. We have had 28 cases of BA2 identified from our sampling in Fresno County. And keep in mind, we have about 150 positive cases a day right now. So having 28, you know, it's still a very small number of the overall, but it is, you know, it's happening here. And then from what I understand, Madera just identified their first one, and that's probably just the tip of the iceberg there too. So you're going to be hearing more about the BA2 variant kind of being found across California. Again, we don't expect that it will create a huge uptick in the number of hospitalizations, but it is something obviously for us to track epidemiologically. Same thing with the wastewater surveillance. There are many jurisdictions that are doing it now, which is really cool. And they're all sharing information. And some jurisdictions are seeing very tiny fluctuations, which honestly we see also in Fresno when we do our wastewater surveillance. And so the news is not all a downward slope is I guess what I'm trying to say, that there are going to be tiny fluctuations up and down. And unless those really lead to a big surge, that's exactly what we should treat them as, is tiny fluctuations up and down. Right now, that's how I'm choosing to interpret the information that's coming my way. Anything to add to that from anyone, or any questions about that? All right. In terms of best case, worst case scenarios, I mean, you know, I think the best case scenario is that there's no more new variants, that we've seen this thing has mutated as much as possible, and it's not going to mutate anymore, that people get, you know, really smart about vaccines and accept the vaccines. And we have, you know, an astronomical number of people demanding vaccines, and we get to not only beyond 70%, but hey, let's just aim for the stars. Let's say 95% of our folks get vaccinated in all eligible populations, which means school-age populations. That our medical supplies, meaning pharmaceuticals against COVID, and also just the supply chain in general for the PPE and stuff like that, get secured and sustainable in a way that we don't have massive disruptions from winter storms, which did happen, or, you know, economic disruptions, which also happen, or just overseas supply chain things that happen with different surges going on and things like that. So, you know, a sustainable supply chain is established for both COVID medications and supplies and non-COVID medications and supplies. To me, that's the best case scenario, right? So now let's look at the opposite of that. What is the worst case scenario? So the worst case scenario going into this summer and fall is that there are new variants. And keep in mind that, you know, we know this thing has crossed into animal reservoirs. There's actually deer that have now caught it. And then, you know, the more animals it finds, the more it can mutate and then jump back into humans, et cetera. We know that new variants are being identified all the time. We know that our vaccination landscape is quite polarized, and that some people are just not going to be accepting this pretty benign vaccine. I mean, you know, we continue to do surveillance and we continue to find at least anecdotal evidence that some people have a little bit of a reaction, but overall the vaccines are extraordinarily protective, even with these new variants. But we understand that, you know, worst case scenario, the vaccine demand just drops off a cliff and the booster demand drops off a cliff. And then the other worst case scenario is that, you know, medications remain in short supply as they are now, and supply chain disruptions really upset our healthcare in general and our ability to take care of people. So I wanted to flesh those out, not that I want to be a Cassandra and really ruin your St. Patrick's Day celebration, but I think that we do need to think about what's at stake here. You know, what are the best case, worst case scenarios for us as a society, as a larger, population nationally, but then also more locally here. Which of those can we chip away at, or which of those can we actually help turn in the right direction? And that's why, in my own mind, at least, I try to think through what these scenarios look like, just so that we can understand, what kind of metrics should we even look at? Like I said, you've heard me complain that COVID is not all what hospitals are struggling with. And I'm sure it's the one of the many things that you yourself are dealing with on a daily basis at this point. But COVID is all, that gets all the attention. And so how do we shift from, exclusively thinking about COVID all the time to other issues that also have healthcare import and that we really need to get to in order to prepare for the next surge? In all likelihood, there will be one, whether it's this summer, this fall, or this winter. It's anyone's guess. We sort of had all three of those already, right? So we had one in the summer of 21, we had one in the fall. I'm sorry, we had one in the summer of 2020, one in the fall of 21, and one in the winter, both winters of 21 and 2020. So we're not sure exactly what the rhythm of this virus is going to end up being, whether it's going to cause 1 peak a year, 2 peaks a year, or 3 peaks a year. I think it's still anyone's guess. But supposing that it's not gone away for good, it is going to come back, and we do need to prepare for it. I guess that's my take home point. And we'd love to have your input about how we can do better to do that, so that we can take all the lessons learned from the past and then be even more ready and resilient moving forward, and really ratchet up testing as soon as we get a sniff that there's a new variant in town or an uptick in cases. Ratchet up our ability to provide medications to our most vulnerable patients, and really get the education and the messaging right, so people have good sources of information, so that we minimize confusion and minimize redundancy and contradiction in what everyone is trying to do. I'm gonna send out some great articles that talk about the medical supply chain. Just a great article by Dr. Osterholm, who's a venerable authority at this point, working at the Center for Infectious Disease Research and Policy, or CIDRAP, at the University of Minnesota. And he's got a great article called The Pandemic of Unknowns, from which I gathered a lot of these thoughts, to be honest. And just a few other articles that I've been looking at and reflecting on that, hopefully you'll find time to read. I think this is a time that I think all of us are doing a lot of reflecting. Certainly the media is asking us to talk about the 2-year anniversary of the first COVID case here and talk about what everyone has been through. And I think that's entirely appropriate, but we should also take away lessons learned and lessons for the future, so that we can actually grow and develop our resilience by doing some strategic reflection and planning around those lessons learned. Any questions or comments on that? Those are all of my remarks related to COVID. So I'll move into non-COVID announcements if that's okay.
Dr. Vohra?
Yes, sir.
Yeah, I have a very boring administrative question.
Okay.
You had mentioned a couple, I think it was a month ago or so, that there was going to be some rescissions on some of the public health office orders. Did those take place?
Yeah, good question. Let me get back to my team and see how they handled that. I think that what we wanted to do was to align with the state orders and then take down our orders. And whether that's officially been done or not, that's a good question. I don't know where we are in the loop on that. I apologize. I'll definitely get back to you on that, and I'll actually add that on my list of items to send out with my notes so that I don't forget it. That's a great question.
Yeah, that'd be great, because we do have some policies pointing to the Fresno County Public Health Officer orders, and if we need to repoint the state, then we just need to do that.
Sure. Okay.
Great.
Yeah, we've slowly evolved, for sure. When we had local orders that were really strong and quite different from what the state had on the books, we've slowly tried to align with the state and kind of massage these orders to be as congruent as possible. But I understand that, we made the announcement that we were going to resize these orders, and I don't know that that's officially been done. So I'll check back on that for you.
And I have a question. Can you hear me? I'm sorry.
Yes. Hi.
Okay. Hey, this is Raquel. I have a question with respect to what is the current climate for laxing visitation in our hospitals in the community? Any guidance about that, or if CDPH is going to adjust anything as we look to do that regarding the screening or vaccination proof?
Yeah, I know that they've released a lot of AFLs, but I don't know that they've revisited the visitation policy as yet. But that's a good question that I can do some research and get back to you about. To me, like, as you know, just my own personal opinion, this is as good as it's going to get. So, to me, I don't think that we should wait for any better numbers than what we have. I really don't. I think, universal masking in healthcare is here to stay. I see that being done, and I don't see anyone complaining about that. We understand, no matter how we feel about masking in general, at the grocery store, at schools, et cetera, I don't think anyone's arguing that you have to have a mask at all healthcare campuses at all times. At least that's been my observation. I don't know if anyone else has different observations or different anecdotes and experiences. But to me, as long as that's being followed, and you could do whatever other screening you feel comfortable with, then I have no problem with visitations, as long as it doesn't disrupt clinical care. But I can try to track that down and see if the state has officially weighed in on that.
That would be great. I think that's how we feel, just depending on the staffing situations, but wanted to see what other folks in the community are doing.
It's a double-edged sword. I mean, as an ER person, there's certainly family members that are very helpful to have at the bedside, and then there's family members that are quite the opposite. So it's a double-edged sword. I get that. Visitation policies can be quite disruptive in some ways, but they can also be quite helpful and healing in other ways for patients. I get the balance that has to be struck there, but I'll try to find out for you.
Thank you.
I'm just taking some notes here so I don't forget. These are great questions. Any other questions? Is masking still required for a low risk clinic? Yes. If you're in clinical work at all, whether you're a methadone clinic or urgent care, a walk-in, even a pharmacy, really, per se, you need to have a mask policy in place. Okay, let me talk about just very brief, just miscellaneous announcements. They're not so miscellaneous to the folks who require these services, but all of us should be aware. I see my friend Chris is on the call. Chris, feel free to unmute and chime in about this issue, but we need more blood donors again, and we really need everyone to try to work together. Like I said, it would be great to bring back the blood drives if we at all can. I know that that's quite a lift given everything else that everyone's doing, but whenever we partner with organizations, I mean, public health has had multiple blood drives throughout this pandemic. We know other county sites have hosted it. We know schools and possibly other clinics are experienced at doing this and would like to host if the stars aligned. So let's think about how to do it. In the meantime, please, if you can incentivize or reward or nudge your staff to go donate blood, we just need healthy donors to give blood so that we can continue to supply it all over our hospitals and clinical facilities. And I'm sure Chris agrees with me that, we're putting out this call because it's necessary. It's time to remind people to give blood again.
Yeah, thank you, Dr. Vohra. Yeah, right now we're just barely holding steady with type O blood. And we're doing everything we can. We're running all kinds of campaigns to try to attract more donors to come in. But, I think just a lot of bad news in the world has sort of depressed people's enthusiasm. But we need to remember that we got to take care of our own right here and get out and donate blood. So we need all blood types, in particular type O right now. Thank you, Dr. Vohra.
Sure. Thank you, Chris. All right. Let me make a couple more announcements. Next week is actually Poison Prevention Week. So as a toxicologist and the medical director at the Poison Control Center, this is kind of an exciting, it's always an exciting week for us. We always try to do a lot of different educational activities, remind people about America's poison centers, which are available to anyone, whether you're a clinician, a nurse, a paramedic, or a parent or a relative, or a patient who just has questions. We take
Shannon, will you answer to Dr. Ainello and tell him that you will be the point of contact?
We take all calls, and that's the phone number. Please program this into your phone. You'd be surprised how many people, are out somewhere. You might be out hiking and get bitten by a snake. I hope that doesn't happen, but 3 unfortunate Californians have already had this happen this last weekend that we know about. So the snakes are already biting. When you're out on the hiking trail, you may not have access to the internet, but you will have your phone. And so calling 911 is a great idea. And then calling Poison Control is also a great idea because they can walk you through some of the first aid tips, et cetera. That's just one example, probably an extreme example, but lots of other examples where this phone number can actually not only save a life, but also prevent a hospital visit. Like most of the things that we do actually keep people out of the hospital, and that saves healthcare dollars. Certainly families are grateful because they hear that whatever the kid got into or whatever they took is not going to cause a problem, and we can keep that person at home. But obviously we need to know the details before we make a blanket statement like that. So that's why we ask people to call us on the line so that we can tailor our advice based on exactly what medication or exposure or chemical hazard they had. So National Poison Prevention Week next week. I'll be at the zoo doing a Facebook Live from the zoo where the herpetologists will be talking about snake bites, and I'll be talking more about the envenomations from snakes and some of the first aid and anti-venom therapy that we are able to offer to our snake bite patients. We're also going to be talking about lead poisoning tomorrow on our media call. Lead poisoning is still out there, folks. We still get calls about that on our poison control hotlines. And if you're dealing with kids, then certainly you should be aware of the lead guidelines and how to get that testing done. There's many other situations that lead can actually enter the person's diet, either through foods or spices or even pottery and different ceramics, usually made in other countries. Lead paint, thankfully, is not as big of a deal anymore, although older homes still have lead paint here in our area. And leaded gasoline, thankfully, is totally gone. That's probably one of the great public health victories, probably second only to smallpox, in my opinion. Getting rid of smallpox and getting rid of leaded gasoline, excuse me, probably did more to help protect public health than just about any other campaigns in the history of medicine. So it's just a very interesting poison that we continue to learn about. We should probably dedicate a whole half hour to a whole hour of our time to learn about lead, just because it is something that our whole community should know about. So we might schedule something like that, either as part of these calls or as a freestanding webinar for you in the future. Next, we have the 71st annual Yosemite Postgraduate Institute coming up. 71st annual. So Fresno Madera Medical Society is just such an institution that we forget just what a pillar of our community it's been. And basically, this is coming up in April, in just a few short weeks. You can register here. I'll share out this link with everyone, and you can follow up with Fresno Madera Medical Society if you have any questions. So please consider attending that event. It's a beautiful venue right outside of Yosemite, and just a great group of speakers, including yours truly. So it is a shameless plug, but I'm looking forward to listening to all the other talks, actually, because I always have a great time, and I'm sure it's going to be just a fun weekend. So look for that if you're interested in registering, and we'll see you out there. Next, also related to Fresno Madera Medical Society, UCSF Fresno and several other partners, including the health department, have actually been able to partner with the Fresno Madera Medical Society to put together a survey related to climate change and the health impacts of climate change. So this is known as the Climate Health and Equity in Fresno Survey. It literally takes 2 minutes. It's only 3 questions. And also a follow-up question about just getting on our mailing list and getting more involved in our new coalition called the Central California Climate Change Clinical Collaborative, or C6. You've heard me talk about this before. You've heard our emergency medicine residents talk about various different aspects of climate change. We will continue to feature those topics, but really this is a way for us to learn what your priorities are when it comes to environmental health, and climate resilience in the populations that you're seeing. What disease processes are you most worried about? Which vulnerable populations or issues are you most interested in pursuing? And if you'd love to be a more active member of C6, this is your chance. Literally, if it takes you more than 5 minutes, then I'll be very surprised. We made this a very short, sweet survey. And I'll share out the link. So please take time to fill it out. I think it'll actually be quite instructive for you, because the residents who put this together very carefully thought through all of the different climate health impacts. And then they just have a list that you can check off. And I was very surprised to learn, as I continue to learn, about climate change and the many different health impacts of climate change. But it'll be instructive for you to go through this survey, but then also take you a very short time to complete it. Please consider doing that. You've probably already gotten this link from the Fresno Madera Medical Society, but if you haven't, I'll share it out with my notes later today. And lastly, just because it's spring harvest time, we actually have a lot of agriculture workers. In our county, we have probably about 90,000 agriculture workers. And this is the time when a lot of agrochemicals get used, just as different agricultural activities start ramping up in time for the harvest. Remember that pesticide reported illnesses are a mandatory reporting diagnosis in California. And when we say mandatory reporting, it's not that hard to do. It's just like other confidential morbidity reports. You've probably filled those out for seizures or dog bites or other reportable conditions. Certainly a lot of infectious diseases, including COVID, are mandatory reporting diagnoses. Well, so is pesticide-related illness or exposure. A lot of people don't know that, but it is something that's important for us to be cognizant of, because we live in Central California, which is a massive agricultural region, and we really owe it to our community and the populations that we serve to make sure that they're as safe as possible, whether they're at work or away from work in their home and using pesticides there. Lots of stories that I could go into about things that the Poison Center hears about. And in fact, the Poison Center is a great way to fulfill that mandatory reporting requirement. If you just call that 1-800 number that I shared with you, and then just say, hey, I have a case of someone who got some pesticide on their skin, or someone who was exposed to, a chemical on a farm. As long as you report that case, then you've already fulfilled your mandatory reporting requirement, and you get real-time advice about what to do with that patient. So you basically have both of those boxes checked off, and it's a great collaboration that we've had for many years through poison control. The other way to do it is actually to fax or fill out an electronic form that gets sent to public health. And certainly, all of that is relayed here on this website from the California Office of Environmental Health and Hazard Assessment, which is actually who aggregates all of this data. And they can actually go out and do investigations if needed of, like, if a place of employment is just not practicing safe practices, or if there's some education that needs to be done. This is not a criminalizing initiative. This is not to get anyone in trouble. This really is the Department of Public Health trying to go out and educate and prevent harm. And they really just have a great set of people that are very knowledgeable. I call them quite frequently whenever I have a question about pesticide stuff, and they're very knowledgeable. They know a lot about the laws and also the basic science and the basic medicine of agricultural chemicals. So just keep that in mind. We see lots of pesticide-related illnesses here in Central California. I don't think all of us are aware that this is a mandatory reporting requirement, and it's something that we do need to keep reminding people about. So I'll put this link in there too. You can read more about it or watch this quick video about how to do pesticide reporting. Like I said, the easiest thing to do is just to pick up your phone and call poison control at the time that you're seeing the patient. That's really the best way to go, but there's other avenues as well if that one is not suitable. Any questions about that? All right, and it looks like Sim, thank you, Sim. Sim just dropped a bunch of AFLs and other CDPH announcements into the chat. And this is basically just different CDPH orders. Like I said, there's a lot of AFLs that just got dropped and I'm still kind of trying to digest them. I was not able to make the CDPH meeting yesterday because I was on a shift in the emergency department. So I'm waiting for those notes to come out so I can catch up to hear what they said. But if you are in a position and have a hobby of reviewing AFLs as soon as they drop, then you can go find a half a dozen new ones that were dropped yesterday. Otherwise, if you want to just wait to see if this applies to you, then I will definitely try to digest them and then share them next time we meet. And so, like I said, so I don't even know if all of this applies to what we do in clinical medicine, but there are a lot of AFLs out there now. And that's really all I have. And Dr. Mitchell's asking, what day will I be at the zoo? And that will be, I think it's going to be live streaming on Tuesday, this 22nd at 11 a.m. So we'll have media out there. We'll have some of our emergency medicine residents out there. And then I'll be out there with the zoo staff. Like I said, we do this almost every year and it's always a lot of fun. So I'm looking forward to doing it again next week. And I won't be touching any snakes, don't worry. All right, so I think that's all the questions and comments in the chat. Are there any other issues that we wanted to bring up today? All right, well, we've given you a lot to think about. We'll give you more to read a little bit later today. You've given us some homework, which is great. I look forward to getting back to you about those points, and we'll convene again very shortly. I think we're probably going to stick to a once every 2 week schedule unless something really big comes up and we need to start doing once a week meetings. But I really value this conversation so much. And like I said, we have a lot of other non-COVID stuff to talk about as a community. And I'm really looking forward to and excited about tackling some of those issues. So I hope that you're able to continue to keep joining us and keep suggesting and asking us questions, and we'll learn together as a community. Thank you all so much. Have a great St. Patrick's Day. Go drink a Guinness and be safe out there. Thank you.
Thank you.
Take care.
Thank you.